Let me welcome everyone at the Congress, Mr. Chairman and distinguished participants. Let me to present the report to the next topic. Early correction of strabismus in children aged from 3 months to 3 years. Literature overview. Pediatric strabismus is one of the common issues in pediatric ophthalmology, and it must be treated early to maximize the potential for binocular vision and decrease the risk of amblyopia. Treatment goals include good vision in each eye and straight eyes. Both conditions are necessary to produce stereopsis, which is the third goal. The eyes of most children are not at atropic birth, but rather mildly exotropic. Neonatal misalignment typically results by 3 months, and any strabismus occurring after this age is abnormal. Esotropia occurring in infancy can be caused by a variety of disorders, including congenital fibrosis of the extraocular muscles, Duane syndrome, and infantile myasthenia gravis. In most of the ophthalmology literature, these rare secondary causes of esotropia are not included under the category of infantile esotropia. The etiology of primary infantile esotropia is a source of controversy and remains unknown. Treatment of infantile esotropia is surgical. Early surgical realignment in infantile esotropia appears to result in better outcomes than this later intervention. The duration of misalignment may be the major predictor of the outcome. High-grade stereopsis after surgery is extremely unusual. Recurrent strabismus is common in children with infantile esotropia. Overcorrection and undercorrection of the original deviation as well as vertical misalignments can develop throughout life, and multiple surgeries are often required. Correction for infantile strabismus is applied only under hyperopia 2.5 diopters and higher. Correction is applied to reduce the degree of accommodation that should automatically lead to a weakening of convergence. So the purpose of the study was to assess efficacy of the treatment of strabismus by the modified correction of refractive errors in children aged from 3 months to 3 years. Methods. 40 children with concomitant strabismus were examined. At baseline, angle of deviation was measured using the Hirschsprung test, and eye movements were assessed. Then refractive error was measured by the short-sighted refractometer with child method without cycloplegia, followed by an installation of atropine. Repeated refractometry was performed 15 minutes later using the short-sighted refractometer by adult method, followed by an accurate retinoscopy. The axis of astigmatism was measured by both a refractometer and retinoscope, and then compared. And if the axis differed by parameters, the measurement was repeated. The slightest change in the child's gaze or return of the head led to a change in results. Retinoscopy data were taken as a basis for refraction readings, and refractometer readings were taken as a basis in cases of minor differences in the data of the axis of astigmatism. The correction was conducted with the aim to achieve maximal visual acuity in each eye, paying special attention to the astigmatism up to 0.5 diopters. If necessary, direct occlusion or penalization were administered to the children. Patients were examined 1 and 6 months later to assess outcome of treatment. And the results. Mean age of the onset of deviation was 5.9 months. Mean age when the spectacles were prescribed was 15.9 months. 24 children had hypermetropic astigmatism. 8 had myopic astigmatism. 2 had mixed astigmatism. 5 children had hyperopia and 1 child had myopia. 39 children had esotropia and 1 child had exotropia. The angle of deviation ranged from 5 to 50 degrees by Hirschsprung and was constant. 8 children, despite esotropia, had a myopic refraction. In 7 out of 8 cases, the correction has led to the eye alignment. In 27 of examined children, strabismus occurred up to the age of 6 months. The deviation in 18 out of 27 children with infantile essential esotropia was eliminated by the modified optical correction. The angle of deviation reduced but not eliminated in 7 cases, and 2 infants still had strabismus. The results of the research showed that eye alignment is achieved in children up to 3 years in 67.5% of cases. Reduction of the angle of deviation was observed in 25% of cases, and lack of effect was in 7.5% of cases. Eye alignment was achieved mainly in children with a shorter period between the onset of strabismus and the eyeglasses prescription. And let me present several examples. This infant deviation of esotropia 15 degrees, onset of esotropia 4 months, spectacle prescription 10 months, and the result symmetrical eye position. This child deviation of esotropia 20 degrees, onset of esotropia 4 months, spectacle prescription 18 months, and the result residual 5 degrees deviation. This child deviation of esotropia 30 degrees, onset of esotropia 15 months, spectacle prescription 18 months, and the result symmetrical eye position. This child deviation of esotropia 15 degrees, onset of esotropia 2 months, spectacle prescription 7 months, and the result symmetrical eye position. This infant deviation of esotropia 15 degrees, onset of esotropia 2 months, spectacle prescription 6 months, and the result symmetrical eye position. This infant deviation of exotropia 20 degrees, onset of exotropia 2 months, spectacle prescription 9 months, and the result symmetrical eye position. Conclusions and discussions. We suggest that in order to restore the symmetrical eye position, the creation of an equally clear image on the retina of both eyes should be taken into account during the correction, along with the accommodative factor. Distinguishing feature of this correction is the creation of maximally clear image with the elimination of microanisometropia on the retina. Using modified correction immediately after the onset of strabismus may lead to the eye alignment in overwhelming number of children. In our opinion, small differences in the clarity of image found on the retina may be in some cases an important factor hindering the development of stereopsis. So here we face such issues as sensitivity to initial conditions called butterfly effect.